Ladies and gentlemen, please welcome Lily Farhang of Human Impact Partners.
We're going to have our speakers join us, and they can introduce themselves because they do a much better job. Come, Ayana, Isabel, Chet. Hi. Hi. How are you? We were just in another room, and now we're up here together, so it's an easy transition. How's everybody doing? Yeah. So I'm Lily Farhang, and I work at an organization called Human Impact Partners. We're a national organization headquartered just across the Bay Bridge in Oakland. And we, let's see, we do a lot of things. So I'll just say a word about Human Impact Partners before we sort of jump in and have this conversation. So we call ourselves a health and racial equity organization. And really what we're trying to do is shift material conditions, structural conditions in communities so that people have the resources that they need to live healthy lives. So we do a lot of work on economic security, on housing, on the criminal legal system, on immigration, and really trying to shift policies and systems so that people have access to high quality and affordable housing, so people have access to jobs that don't steal their wages, but actually pay them, what they're owed. And we do advocacy around those issues, we organize around those issues, we do research around those issues. And then there's this other body of work that we do with governmental public health here in the US. We're a domestic organization. And that work with governmental public health is really trying to transform the field to kind of focus more on these upstream factors, but also to change the culture within governmental public health specifically to be prepared for a pandemic like COVID. And so what we're here today to talk about is kind of life in the health equity space in this post-COVID context here in the US and also internationally, and kind of what does the future hold for those of us who care so deeply about what came before COVID, what predated COVID, COVID itself, and what we now have to contend with in the future. And so I'll just say a teeny bit of background about myself. I have a background in public health. I worked at the New York City Health Department. I worked at the San Francisco Health Department. And now I run this national nonprofit organization. I think of myself as a public health person through and through. I love those people. I deeply appreciate the people who do that work. And I have a lot of empathy for them right now, particularly in this hyper-politicized climate in the US, where the public health community kind of flew under the radar for a long time. And now all of a sudden, because of mask mandates and stay-at-home shelter-in-place orders, people are being threatened and attacked in public meetings while trying to perform public service. So I'm feeling deep sort of empathy. I have 2 kids, 11-year-old and an 8-year-old. They gave me all my gray hair. I'm from New York. My parents immigrated from Iran, and I grew up in a pretty political home, as people do when they often migrate out of country for political reasons. What else? I love the Golden State Warriors, so if you want to talk basketball, please come to me. They're having a rough start to their season. And I also watch a lot of television, so if you want to talk, that's what I do to numb my mind at night. So please come chat. I feel like we are not just our professional selves, so just a little bit about me. So before I kind of turn it over to the panel to start to hear from them, I want to just share a few sort of operating assumptions for all of us. Sort of the way I think of it is what are the baseline agreements that we all have that form the foundation of the subsequent conversation that's going to happen. And I think from what I understand, many of you were here last year when the focus was on health equity and the social determinants of health. And so some of this will probably resonate for those of you who were here last year. But really the sort of first assumption that I want to share is that COVID, in a lot of ways, just exposed decades and decades of disinvestment in our public health, healthcare, and social safety net systems. So, and that wasn't by accident. That disinvestment didn't happen by accident. That was actually like a very targeted political strategy here in the US, in particular to starve the public sector systems in order to prop up, in many ways, private alternatives. Some people might disagree with that, but that's an assumption that I will just lay out for this panel to kind of contend with. And today, the public health system really only claims, I think it's something like 3 cents for every health dollar that's spent here in the US. So that's kind of like the in some ways, political kind of context that COVID, happened in. And I think the pandemic, and this is not going to be new to many of you, showed us that the biggest driver wasn't really a germ that was transmitted through individual behavior choices, but it was material conditions that constrained and created opportunities for people to make those choices. So did you have high quality housing that you could go home to? Did you have a job that protected you while you were at work? Did you have paid leave? Were you able to take off? And so all of these kind of larger systemic forces and policies are what really created risk in the COVID. It's what created your risk of getting COVID. I mean, frankly, putting aside death, actually just exposure happened basically through a lot of these kind of social and economic conditions. And so that's, and all of those conditions, frankly, in the US are driven really by what I would say deep power imbalances and structures of privilege and oppression, primarily structural racism here in the US, but also other dimensions of identity. So that's one assumption I'm gonna lay out. You can choose to disagree with it, but I will just say that's an operating assumption for us at Human Impact Partners. And the pandemic really magnified, I think, and illuminated cracks that existed in all these systems, and the consequences of those were borne on the backs of Black, Indigenous, and other people of color and low-income people here in the US. And so I think the second assumption I'll just lay out there for people to keep in mind is that this experience is really nested in kind of pre-existing economic and social crises. Here in the US, we have the highest levels of income inequality that we've had since the Gilded Age. It's just true. And so many of the communities who were hit hardest were already contending with failures of their governments, failures of their elected officials, failures of the private sector. And so that's the wider pre-existing conditions upon which COVID sort of landed. And I think so when I think about what the future holds, it's not just responding to what the past 3 years were, but it's actually responding to what the past 3 years have really illuminated and magnified, I think, for so many of us in the health sector. And so it's within that context that we have people really, I think, trying to reimagine what public health is, what public health should be, how to tackle these inequitable kind of structural and social conditions from their unique vantage point. And I think leaders are in the health and public health spaces, and this is true nationally and internationally, are much more explicit about the social determinants of health and the importance of really shifting mindsets and narratives that kind of make social determinants work normative public health practice, right? So how do we make work on material conditions normative public health practice? Well, it takes leaders actually constantly trying to tell their story and have that be part of kind of a wider narrative discussion. And so I think the thing I want to say, I know a lot of folks in the room may not think of themselves as health funders, is that what drives, my point is that much of what drives health actually doesn't happen in the health space. It happens in all of the other sectors, along with what happens in the health sector. And so there's room really for people in education, philanthropy, and economic security, philanthropy and housing, to be thinking about what are the points of connection that can ultimately drive positive health and decrease health inequities. So with that, I have 3 folks joining us for this conversation. And I'm going to keep intros short because I actually think it's more fun to let people tell their own stories. So I have Chet Hewitt, who's the president and CEO of the Sierra Health Foundation. I have Ayanna Bennett, the director and chief health equity officer of the San Francisco Department of Public Health's Office of Health Equity, which I used to work at the San Francisco Department of Public Health, so it's fun for me. And then I have Isabel Kamariza, who's the founder and president of Solid Africa, which is based in Rwanda. So I'm excited to turn to them to hear their reflections on how to advance health equity coming out of COVID. And my hope for each of you in the first few minutes, and we'll start with you, Isabel, is to just kind of share with all of us, like given your place in the ecosystem that I just described, like, what's your story in your own words? Like, how did you get here? Not how did you, or what, I took this plane and this train. But how did you get to the work that you do? How did you become who you are today? And then if you could also tell us what's your area of focus kind of in this health equity ecosystem, that would be great.
Yes.
Yeah.
Thank you so much, Liddy, and thank you, everybody. How did I get here? So let's be short. I think it all started when I was in university. So I was studying law in Brussels, coming from Rwanda, and I didn't really like law. So I was actually just studying for my parents, for the family, for my sisters, and I always has been bright. So I was just studying to study. But I think on my third year, it became really kind of impossible for me to continue. So I decided to drop out of law school, and I didn't have any plan B, and I couldn't tell my parents because I would know the question would be, okay, now you stop law school, what are you going to do? And I was raised really with the idea that you have to have a diploma to start your life. Like without any education, you can't succeed in life. So I was kind of afraid because I didn't have any plan B. So I decided back then I worked. So I decided to take 3 months and read the Bible. And not because I was a good Christian before, but because I thought, I don't know what to do with my life. I'm not excited by anything. And people say, all the solutions of the world are in this book. So I said, let me take the book, read it consciously. So it took 3 months, read the Bible. Didn't understand a lot of things, but what I did understand, what I really did understand was, at the end of the day, what they would ask us is the impact we had on other people. Who did you clothe? Who did you visit? Who did you feed? Is really what did you do for others that were less fortunate? And then to go back to my life and assessing my life and just noticing that I didn't do anything for anybody. I always had excuses. I'm young, I'm studying, I'm broke, I don't have money, I would look for a job, work, have a lot of money, and then I would help a lot of people. Those were the excuses that I had. So being in that mindset in Brussels, I started noticing homeless people living there. And then from that, I said, now that I've seen it, how can I do something? So I started feeding homeless people in Brussels and noticing that it was only costing me €1 to feed somebody. So that's really the beginning of my journey. I always has been passionate about food. And for people that knows me, food is my love language. If I cook for you, it means that really I like you. So that's really in that mindset that I went back to Rwanda, because also I told my parents, then they came seeing me in Brussels and they were like, so you drop out of school, you are feeding foreign people in a foreign country, you need to come back home. So when I came back home, I met an amazing woman, and that woman brought me to public hospitals. And just pointed out the fact that in our public hospitals in Rwanda, food are not part of the hospital stay. So you have to have a family and friend that will come every day and feed you. And when she said that, she said, let's go to the hospital. We went to the hospital. She knew exactly which patient we needed to see. She already had planned everything. She was so clever. So when we got there, our first patient, it's a girl. She has the same age. We're in our early 20s. And then she's so skinny. So I asked, but have you even eaten? And she said, no, it's been 2 days. And mostly when people are coming at the hospital, They notice that I'm an orphan, I don't have people coming seeing me, so they would want to share the food with me. But I have such specific diet that I can't even eat the food that they are bringing for me. And that's how we started Solid Africa. So we started Solid Africa to give food and nutrition security to patients in public hospitals, because as I said, relying to family and friends become really challenging when you are living too far away from the hospital or when you are already coming from a low-income family setting when you are struggling eating. So we started by feeding 5 people on a daily basis, but giving them that security that will come every day, and specifying really in special diets. And we are now feeding 1,300 people on a daily basis with 3 meals a day. And we make sure that we do cut off for specific diets. We have what we call a farm-to-fork approach. So we farm 84% of the food we are delivering. Then we have an industrial kitchen where we cook and dispatch the food in different hospitals in Kigali. So this is really what we do on a daily basis.
Thank you. I love that. I love that.
I hope you like me enough to feed me one day. I hope you like me enough to feed me one day.
Chet, what's your story?
Well, a very different story, but some commonalities. I guess we're both reformed lawyers. I actually finished law school, but decided that there were other things in the world to do. But, you know, journey, born in New York City, one of 8 kids, grew up in public housing, if you know our system here. Grew up in a community that was overwhelmingly black and brown, and didn't know I was poor until I left. Right? Because when you encounter the world and you see the kind of resources, opportunities, and privileges communities that were not like mine actually had, it really kind of reshapes your opinion about who you are and what the importance of your work is. In 2 ways. One, the kind of vibrancy and uniqueness of the place that I grew up, the fact that the adults there could protect us and encourage us enough to not feel as if we were, you know, suffering from a lack of material investments. You know, that's what a strong community can do. It's prophylactic in its nature. It protects you from things that could do harm to young people. And draw a lot of my passion and motivation from those particular experiences. Moved to California many years later, was in philanthropy, a fellow at the Annie Casey Foundation, worked for the Rockefeller Foundation in New York City for a number of years, opened up their West Coast field office, working around the intersection of employment opportunities and human services. Right? How do those things really interact? And in what ways could you invest in communities if you married those 2 elements with community and economic development? Right? Could you really produce healthy, vibrant communities where health was not just about your access to clinical care, but a healthy economic environment, a safe environment, and one that was supportive of young people and healthy development. From that, I was also a director of social services for Alameda County for many, many years, director of its child welfare department, before coming to the Syria Health Foundation, which is a health conversion foundation, which means that it's not anyone's private wealth. It was a nonprofit health plan that was bought by a for-profit entity and created a foundation. There are many, many of these types of institutions in the States these days, some very large ones like the California Endowment, but we were actually the first one west of the Mississippi. We have always been a social determinants of health-focused foundation. All right? 85% of your health has nothing to do with your ability to get access to clinical care. Health in that way is a derivative of an illness or someone being sick. We're really focused less on the treatment of health conditions, and more of the production and promotion of a healthy people. And they really do require you to think differently about the type of interventions that you actually deploy. And at the foundation, I'm also the founder, after being there for a number of years, of the Center at Sierra Health. And the center has been a major intermediary for California's response to COVID. So we did things like the public health announcements before we had a therapeutic intervention, which was really behavioral based. We've reached about 11 million Californians. We've invested in partnership with public health, labor and workforce development, about $340 million over the past 3 years. I will say a couple of things about the importance of this particular work and our unapologetic focus on racial equity and social justice. Because, as my colleague said, the most powerful determinant of who got sick and who died in California and in this country has been poverty. Right? For all the social reasons, for all the upstream reasons that you talked about, and hopefully we'll talk a little bit more about that as well. Just a little bit about me.
Yay, thank you.
I'm Ayanna Bennett. I'm a pediatrician by training, and my story is even, I guess I'd have to start as a kid. I want to not, but it's hard to not do that. My parents met in college, and they were both Black Panthers until they quit in protest over something. But that really colored my whole childhood. My father gave us a speech before every holiday. Like, I got the Columbus didn't do anything speech before Columbus Day. I got a speech about everything. So I was deprogrammed from the school curriculum kind of aggressively, and really told very early, your teachers believe that stuff and they're wrong. And I felt great sympathy for them. I tried to explain where babies came from to the teacher who didn't understand they were eggs. They were all eggs. Anyway, but that idea that the world has things that are true and that's not exactly what runs things. That, I think, is just deeply ingrained. And so it has led to two different, I think, principles that have run my life. One, that lines are false. Somebody made that up. So almost everything somebody made up, which means that they could be right, they could be wrong, who knows? Let's decide another way. And the other is that racial equity and justice, which I certainly didn't call that, it was just racism in my house, that those things are structural and part of everything. Like, there was a story that went with almost everything. I mean, my dad could tell you about the racism related to the color of bread, but it was everywhere. And I do believe that in many ways, our different hierarchies are organizing principles. They are deeply ingrained, and they help people understand where to put things and how to approach things. And so those two things together have led me lots of places. So I came from a poor neighborhood. I, again, did not know that really all that much. I knew there were other schools that had more than us, but it didn't really seem relevant at the time. I was, a gifted kid. I did sports. I seemed to have a full life. And then I went to Stanford and realized that my school was quite different than my roommate's school. I went to Exeter. It was not Exeter. But I got what I needed, and in many ways was much more of a free thinker than many of the people who had what would traditionally be called more privileged educations. And so I came out of that undergraduate experience kind of with a design my own major, of course, because lines are false, and went to medical school and really found a kind of both sides medical school too. I went to a joint program between Berkeley Public Health and UCSF. And then I graduated, went to residency, and wasn't quite sure what I was going to do after that. I almost took a job at UCSF, and then one of my favorite professors said, I would be incredibly disappointed if you worked here. Not sure what that meant or what I was supposed to do, but I really felt bad about thinking about taking the job at that point. He said, you're supposed to do something out there. Okay, why he was comfortably sitting in here while he was telling me that, I don't know. But so I went out there and I worked for private practice. And a week before I finished residency, I got taken to dinner in Zuni Cafe. It was very expensive, by some community folks who wanted to start a clinic and didn't know how. I have no idea why they thought a new resident would know either.
Because you had energy.
Yeah, but, well, they didn't know. They definitely didn't know. So I said yes. And, because I knew more than them. And my father's other principle was you never step over a mess. Like, you wouldn't get in trouble for spilling something. You would get in trouble for walking past it and not helping. So, they were in a mess. They had no idea what they were doing. And I knew more than them. That's got to be enough at the moment. And so I did that for no pay while in private practice to pay my loans. And I didn't have any kids. I didn't have any reason to need any real money. So I did that for quite a few years, really 10. And that little clinic they wanted to start, I was the last man standing of all the community members who started it. And I was the director of it for many, many years. And it went from a volunteer organization where none of us got paid to the budget now after I left is $12 million. So it was a real lesson in both. I got to drive from my private practice over to my converted liquor store nonprofit and really see every day the difference between what I could offer in my clinic in Alameda and what I could offer in Bayview and San Francisco. And it was entirely different. And there wasn't anything I could do about that exactly. Like, I could give free stuff. I can't give free x-rays. I can't give free money for you to take time off. I can't give lots of things that were more than just insurance payable that people needed to be healthy. And so we started lots of programs. It was really nice. It was small. There were very few employees. So if somebody had an idea, I found some money to do it, and we started it. It was a beautiful, freeing system where we just heard a problem from somebody, saw if that was general, and then we went and found a solution. And then I went into the health department. That is no longer true. And learned, because I just wanted a bigger scope. I'm like, I really love this. I did something, and it feels like I'm done doing that, and now I need to do something bigger. And so I entered the health department in the leadership team and really found many great things. It's an enormous scope. There's enormous resources compared to anybody else. And you have really no other duty but to do good for the public. And I also wasn't getting an ulcer from being responsible for other people's mortgages, and I had to raise money every year to make sure that Katie didn't get kicked out of her house. So it was much more relaxing to kind of just do a job, but at the same time, it is a slog. It is very hard to get things done. You have a brilliant idea. In 3 years, I might do that. It just takes an enormous amount. The public is very generous and very suspicious of what people are doing with their money. So there are tons of hoops to go through, there's tons of documentation, and it is a real barrier to doing good. I actually didn't take a lot of government money when I was running my nonprofit for that reason. They don't pay on time, and it takes too long to get that money. But from the other side of the fence, I can see how much of a struggle it is. We're trying desperately to help you, and it's hard to do. And I sort of designed this Office of Health Equity after taking all the many projects that they had given me and deciding we were never going to get anywhere by picking a disease of the moment and trying to help people in that disease. And so taking all of it and deciding to move it all to be more structural. So my office is mostly policy and quality improvement and things like that. I don't spend a lot of time training, which is everybody else's main thing. I do some, we do some, but it's on the job. So my goal is that your actual job, not a new job, not we created a program, but your actual job you already do is no longer causing inequity or is suddenly now advancing equity. So if it is the people at the front desk who are, their behavior is keeping people from coming, if it's our no-show policy, whatever the thing is, there is some problem everywhere. The principle is if you disaggregate the data, there's a gap. It's almost always the same gap. It's Black people, sometimes Pacific Islanders down there, Latino immigrant people, sometimes Asian and white, sometimes white Asian, Native Americans float depending on the issue. So there is a hierarchy that organizing principle, that same list works for unemployment, it works for house ownership, it works for heart disease readmissions, it works for almost everything. And that's because it's an organizing principle. So what kind of housing you get, what kind of medical care, all of those things have to organize around that because it's basic for us. Then COVID happened. As part of the leadership team, somehow I ended up with the duty of being incident commander of the San Francisco response. If I ever thought I had it all, so I had a new one. It was very illuminating and very banal. So lots of things changed, but not where the problems were. I remember the day we geo-mapped where the COVID cases were, and they were it looks exactly like our asthma map. It looks exactly like our heart disease map, which looks exactly like the redlining segregation map from 1932. It has not changed. And we have a lot of things to work on, but those things are old, and they are solid and hard to move, but that is where the problem really is. So that's where I try to focus.
Thank you. We'll come back to that. Thank you so much for telling us your stories. I appreciate that. So much better than me reading your bio. Isabel, hearing kind of Chet and Ayana talk a bit about kind of these root causes, social determinants of health, structural issues as the source of health inequities here domestically, I'm wondering in Rwanda, kind of how do you talk about what the root causes of the food issues are that you're working on, and kind of how did you and the healthcare system have to kind of shift in response to COVID in order to address those root causes that you were seeing play out?
Yes. So the root causes, I think, of course, they will say like poverty in lands. Like Rwanda still have 38% of the population that is still living under the poverty line of earning less than $2 a day. So of course there's that, but for me the root causes are root causes that we can identify and actually find solution as an organization. So one of the root causes that we were able to identify and present to the government is that, of course, in public hospitals, there's like inside and outside restaurants that they give to private institutions. So those private institutions, they bid every year and then they win the market. But they will be selling a meal between 80 cents USD to $1.5, serving a population that couldn't afford sometimes to have $3 a year to pay for our public insurance. So meaning that the solution that they are giving is really not adequate to the problem that the patients are facing. So our solution was to partner with the government and say, you know what, if the government can invest in building kitchens in public hospitals, as I said, because there's no food, most of them don't have kitchens in those hospitals. If the government can invest, then Solid Africa can manage it, and manage it as a non-profit-driven enterprise. The idea is that we don't want to make money in public hospitals, but we want to make sure that the food is affordable and accessible to everybody, regardless of your income. As of now, we are feeding people for free that we have identified with the system, with the hospitals. So the idea is that to feed those that can afford for sure for free, but then to have a sliding scaling model where you are going to pay a portion of the food depending on your earning. And in Rwanda, it's really easy to do that because everybody is categorized into socio-economical category. So it's not something that is really hard. When you come to the hospital, they already know in which socio-economical category you are in. So it's easy for us to really find out and tap into that. The other thing of the root cause is that the issue is not only food, it's access to medically tailored meals that goes with your illness. Because the fact that food is medicine, if you're not eating well, you will have longer recovery rates, you will stay longer in the hospital, that will become congested. But also there's the fact that families that are bringing food to their loved ones, and because it's a setting of a public hospital, most of the time they bring food one time a day. So you're eating something at lunch, you have to keep it a little bit so that you can also eat it at dinner. So all of that causes another kind of problem in the hospitals. So those are the solutions. The other thing that really happened with COVID, I would say that for us, for Solid Africa, COVID-19 was such a magnifier of the issue. We've been talking to the hospitals, to people, creating awareness about nutrition in public hospitals. And when COVID happened, the first lockdown, there were no public transportation, So now even the families that could come to the hospital couldn't move anymore because nobody would take a taxis of $5 to come and bring you food that maybe cost $1. So meaning now the government were calling us and say, how can you now go to the other hospital? How can the food be available now? And then we moved from one hospital we were feeding to 4 hospitals in 13 days, from 400 patients to 800 patients on a daily basis. But that also gave us the discussion we are having now, because now they saw that we need food and we need it in the hospital. And that's why our public-private partnership started, because COVID helped us really to, I would say, fast-track the work that we are doing. And the fact that now, when I'm talking about food is medicine, is that the issue is not only in Rwanda or in Africa, where you are seeing that food that are given in public hospitals, even in other countries where they are giving food, is actually food to, I would say it's like to get rid of you. So I'm gonna give you rice, I'm gonna give you ugali with beans and a lot of water, few vegetables. It's really just to say that I have fed you, but I'm not giving you food that would heal you. And I've been also training here in the US, in Massachusetts, in Boston. They have a thing called community servings, where they're serving meals to people who have chronic diseases. And to end up that they're exactly fighting the same problem that we are fighting when it comes to food as medicine, to medically tailored meals. And us, what we want to do is really to leapfrog. We don't want to give bad food or non-nutritious food or non-tailored food to our patient. How can we give them the better quality of food that is tailored to the illness so that they can go back? And then the fact that sometimes government are, I would say sometimes not brave in the fact that they don't want to venture in new things and also to see what are the different priorities. So for us, it's also to put a cost and saying this is how much you are losing every time you are not feeding somebody with food that is tailored to their illness. And also this is how much you are missing when it comes to the global economy. Because when you are sick, most of the time you are sick with somebody else, a caregiver. So you're having 2 people not working when they're in the hospital. Yeah, I think those are really the root cause.
I appreciate that they're not so brave is the nicest way you could, it's a very nice way of saying that. So, Chet, I'm curious, you described yourself as Sarah Health Foundation as a social determinants of health foundation. And so I'm curious kind of how that grounding really positioned you to respond to COVID. Like where were you really able to double down on kind of existing foundation priorities given your emphasis on social determinants of health? And then how did COVID sort of open up new areas and spaces for you to spread the gospel?
I think a couple of things for Sierra Health. I think that our approach, our social determinants of health approach, really had positioned us over the past decade to develop deep and trusting relationships with community organizations. And that was to be more than a funder, to be a partner. At Sierra Health, we don't have grantees, we have partners. And we're very fond of saying that if you want a grant, there's a lot of people to talk to. If you want a partner, you should come and talk to us. Because while that may seem like it's simply about semantics, the culture that we operate from tries to equalize what is, long-held power imbalances in those particular spaces. When you say you are the grantor of anything, it means you have the ability to give and the ability to take away. Right? When you say you are a partner, then it suggests that there is a more equal distribution of authority. And for us, not knowing that we'd have a pandemic, that table setting became really, really important. And it became really important because not only were we looking more upstream for ways to invest and to help communities resolve their challenges that they identified, but when it came to COVID, one of the most important issues that public institutions had to get over were issues related to trust. And I don't think I can overstate how profound distrust for public interventions really were. We have people in the Black community who, when we talked about the vaccine after it's been developed, who talked about the Tuskegee experiment, which is a long-held experiment where medical treatments were denied to black men for a large-scale syphilis study. Now, that study went from 1943 and ended in 1973. And 50 some odd years later, people would still recall that history as a reason to have skepticism about the validity and the purpose behind the vaccine. So for us, the notion of having a decade of really behaving like a partner made Sierra Health one of, and there are many, trusted institutions to be able to go into communities of color and have real conversations about what some of the interventions would be. I think the other thing that we noticed was that here in California and throughout the country, the public health infrastructure was a community-based infrastructure. We have defunded public health in this country for 30 years. And while we had big ideas around contact tracing and getting people to understand, to wait to get together, and to wear your mask and to wash your hands, that the human capital you need to get out and touch communities doesn't really exist. And so community groups themselves became the conveners of testing sites, right? Became the conveners of vaccination sites when the vaccine was available. Became the trusted messengers to carry, issues around behavioral change and behavioral protections into that community in ways that people would not only hear it, but seriously consider shaping their behaviors. So I think that our history, looking upstream, being a real community partner, having relationships with authentic community institutions that were trusted by people who live in those communities, who were able to push back on some of the concerns, Tuskegee and others, that really became barriers to people being able to protect themselves, their families, and their communities. Another example I would give, and this was largely true in the central part of California, which is heavily Latino, was folks who were afraid that someone knocked on the door that they were coming from the immigration services. Right? Not there to help, but there to collect information, which could result in people being deported and families being taken apart. So there was real skepticism, even in the midst of a pandemic that clearly was wreaking havoc, particularly on communities of color across the state of California. So for us, this racial justice and equity framework, partnerships that were deep, had been established for over a decade, the ability to kind of connect with authentic community groups and authentic community leaders whose voice was trusted by people in the communities, and to leverage that as a part of what I would call the evolved public health system has, I think, resulted in enormous outcomes and impacts here in California and across the country for those places that have adopted, similar approaches as well. I actually say, and this is not a pejorative to my public health colleagues, but we work with the California Department of Public Health, Health and Human Services, Labor and Workforce Development Agency as well, who have done enormous work, but they are understaffed and undermanned for what the pandemic and the challenges it brought required. So I would say that in many respects, community saved itself. And community saved America from what would have been a far more deadly and a far more costly pandemic had not regular people who loved their communities stood up, organized, got educated, and did a phenomenal job in creating a level of trust, because that's why I started this conversation, that allowed public health knowledge to be the kind of protective mechanism that we knew it needed to be over the course of this pandemic.
Yeah, I cannot overstate the importance of that trust piece. Like, we do work with health departments across the country. There's 2,800 county health departments in the US, and we work with a lot. And I will just say that the governmental public health institutions that had the highest success with COVID had the deepest, most trusting relationships with community partners. Like, over and over again, the governmental agencies that hit their head against the wall were the ones that had not invested for years and years and years in repairing historical harm and trauma that they themselves had in many ways, and the institution that they were a part of, had inflicted on communities. And I think, just turning to Ayanna, I will say part of the challenge now is that we have to rebuild a broken public health infrastructure. We want it at the community level, but we also need a functioning government. And I think that there's a lot of people within government who are coming with really positive, I think you used the word earlier, pro-social kind of intentions, who view themselves as doing good in the world. And they're coming into institutions that have been both disinvested in, there's high degrees of mistrust, there's, for important historical reasons, Tuskegee and so many others. And so I'm kind of curious, like, you're in a pot that's got a lot going on. And so when you have a pro-social vision of advancing racial equity, advancing health equity, kind of how do you, how can you make space for that work, like, in that environment? Like, seems like an incredibly challenging environment. And so how do you advance that vision and agenda, kind of in light of what Chet said and your own experiences?
I think there are challenges and benefits. So you do have the resources, which is not true for many of the community groups that desperately tried to save their communities. But you have to be able to give them to people and be able to decide what to use them for in a way that has some respect for partnership. And many, many parts of the way government has grown itself to function don't allow for that. So we get a grant, it has a period in which we tell them what we're going to do. We have to say exactly what we're going to do, not sort of what we're going to do. So the conversation with the community about, hey, what do you want to do about tobacco? There is not time for that. We're going to say what we're going to do. The ability to move the money from the government to the public is, for us, it's really slow. It's not that much better for anybody else. And that is not the speed of trust or change. So during COVID, when we had the city attorney and the controller and everybody was on the side of fast, all rules were off and we were able to do things that we've never been able to do. Hire people outside of civil service, so that somebody who doesn't have the education to pass the test we created but has absolute deep knowledge about the community we need them to go into could actually be paid to do that work. One of the things that is our dependence on low-income people to do stuff for free is really crazy. Like, we don't so much ask middle-class people to do stuff for free, but our inability to pay those community people to go and do those messages, it really makes it hard, and we were able to do it, but we're not able to do it about everything. That is why I always try to emphasize the public-private partnerships, because there has to be some money that can move. There has to be some that can do what you say you're going to do in your conversation with community. That doesn't have a rule that says you guys want it to be in this part, but actually it has to be in this neighborhood. A CDC grant that says you can only work in census tracts with a certain income. Well, you build $1.5 million house on the hill in Bayview, that whole neighborhood is out, and that has happened. So that kind of very meaningful rulemaking in order to try to get resources where they need to go, which is really bread and butter of how government functions, it doesn't fill the holes in when those rules hit reality. So being able to say, we need you to start this project, we need to be able to fund the development process, which, trust me, government grants don't do that very often. Just the ways in which we say equity is supposed to happen. It's supposed to be done in partnership with community. It's supposed to resource community to do those things. All of those things we say are our principles many of them are not possible. So asking staff to try to make it so in that environment is very difficult. They can't give over power. They don't have it themselves. They're just following a set of rules. So they can't do the things that they need to do. They can't hire the community person because she doesn't have a BA. And, so the rules are important and they're there for a reason, but that reason doesn't fit all situations. And we need more flexibility than we have to really be able to do what Chet's talking about and partner in ways that are meaningful and actually lead to trust. I think we did well because we did have some. Like we actually, despite having a few tomatoes thrown at us, we got, I think, years of work made a very non-defensive reaction to that. And then we actually did what we were asked to do. So yeah, I think it's difficult, but we're working with a lot. So even through that difficulty, a lot gets done. It just, more would be possible.
Yeah, so I appreciate that because I think what you're naming is sort of taking stock of the resources and rules the resources you have and the rules you could take advantage of, and the relationships that you've built. And one thing that makes me think of that both you and Chet are commenting on are like the importance of working kind of with communities, with community organizations, the role that they played in saving themselves. And it makes me think about the role of NGOs and how important NGOs are in an environment where the government and the healthcare system necessarily isn't meeting the need. And so I'm wondering, Isabel, if you can talk about sort of why NGOs are so important in the work that you do and who you are.
Yes, thank you. I think on the background of Rwanda, so after the genocide against the Tutsi in 1994, I think we were at square zero where you have to rebuild everything. So there were a lot of international NGO and a lot of NGO that came right away. But what we have seen is that having a leadership, like in Rwanda, we have a great leadership, for them to say, you know what, even if you're among the poorest countries in this world, we will not accept for people to come and work in silo and do whatever they want. And to put, and saying, and it was kind of bold, saying like, stop, everybody stop. Now let's go to the board, to the drawing line and say, this is our vision, this is where we need you. So either you enter in the needs that we have as a country, or either you go in another country. And that has really shaped how NGO works in Rwanda. And it means it's really well organized. So when you come, you see a gap. The first thing we did, even as a local NGO, is really to go to our Ministry of Line, which is the Ministry of Health, and say, this is what we want to address. Where are you in the vision? Is it something, food, is it something that you are planning to solve in 1 year, in 2 years, in 3 years? Is it in the vision? And to understand that food was far away in the things that were needed to be done at that point. And for me, it's not like, how can you make what you are doing a priority? Because at the end of the day, there are so many things to be done. There are so many issues, but how can you make your issue relevant? And that's, I think, the role of really civil society of saying, there too there's a gap, and this is how it is happening. And that's why it is so important in investing in locally led NGO, because we do understand the issue. We do have the solution on how to solve that. And we are needing the funds. But at the end of the day, and that has been said before, is that it's a relationship. So the donors are having something that we don't, but the doers too, we are having something that the donors don't have. So it's like meeting in the middle and understanding that I need you, you need me. It's not me needing you more that you are needing me. Yeah, because I think sometimes also as doers, we come in that mindset of, we are going to ask as if we're begging, which is not true. I'm not a beggar. And what I'm asking for the community that I'm serving is also what the donors that are funding me want to solve those issues. So it's kind of a relationship. And when we come now to the issue of trust, I don't think I will elaborate a lot because a lot has been tested on trust. But it's also saying like, there's no data proving the contrary, proving that local-led NGO, they were like more corrupted than any other organization. So we don't have data to back that up. the mistrust, but it's also, I always say it's like a vicious circle, because what big donors are saying is that, we can't see you, you don't have the capacity to be able to be visible or tell your story or have like a monitoring and evaluation, KPIs, all of that, you don't have the capacity, so we can't fund you. So now, if you can't fund people to have the capacity, they will never be there to ask for that money, to apply to those grants. So it's like a vicious circle of like the egg or the chicken who came first, because then what we need to see is to see unrestricted funding, but also seeing funding on top of that, saying like, what are your biggest capacity building gap? What do you want to fix? And be happy and excited in saying, if this is like a salary that you are needing, if this is a person that you are needing, a structure, this is what we're going to invest in. So I think NGO has a big role in really waking up mindsets on how money should move, but also waking up government. Because at the end of the day, to make sure that you are having the most of impact is to make sure that you are entering in an ecosystem, is really to change. And that's why the work that we are doing in Solid Africa, we don't see it just only changing how food is delivered in public hospital. That model can work in public schools, it can work in prison, it can work anywhere where you are cooking at a large scale. You won't find any competition to Solid Africa in Rwanda, because our meals, because we farm, because we have a semi-automated kitchen, our meals are really low when it comes to cost, but of high quality. As an example, in our kitchen, we only use 9 cooks to cook 9,000 meals.
Wow.
So that already is really cutting the cost so much. So I think NGO are also there to think about how can we create revenues. Because philanthropy, charity, is not a way of living. As he said, tomorrow you can waking up, your biggest donor is like, I've changed the way I'm seeing things. I'm no longer interested in health. Now I'm in education. Or we've seen even with the pandemic, some of the donors were shifting because now there's something bigger happening to everybody. They're shifting their funding to fund more health-related pandemic. So it's to see also how do you create sustainability. As we are generating some of the funds ourselves, around 24%, by giving kitchen management services. Like what we have learned, now we apply it to private institutions by selling meals to private institutions and companies to be able to generate money. But it's also to have funders that are flexible, that can say, if this is your sustainability, let me also invest in that. And not taking part about equity, whatever. That's also another story when sometimes you are creating a social enterprise that you need to be really profitable to be able to feed your nonprofit. And then having the money being out, then can we take equity if it's really a lucrative business? So it's to see all of that, but at the end of the day, it's a relationship. If we can be honest and candid, and I'm talking about donors and doers at the same time, because sometimes us also doers, you feel afraid of saying really this is what is going on the ground. Sometimes also doers ask a little bit of money because they're afraid of saying, if I'm saying a big budget, then they'll be like, no, this is too big for you. Like, how are you moving from 100 to 1 million? As if there were a roadmap on how people scale, on how people do the work. There's no roadmap. Like each organization is trying to solve an issue and really think about the strategies of being able to solve that. So I think at the end of the day, relationship, just discussion, and we should move forward.
Yeah, I'm so curious what you think when you hear that. This donors, doers, the relationships, the sort of fears that I think sometimes the doers or the requesters or whatever are coming with, and what that, like, how do you see sort of the leadership that you display at the Sierra Health Foundation, which takes a different approach to funding, it sounds like, than the normative approach, sort of, like, what would leadership look like more widely in the field to model some of what Isabel is describing?
Well, I think she hit on some really key points. And
Yeah.
that's why I talked earlier about seeing people as partners and this notion of trust. One of the orthodoxies around philanthropy has been, it's a great philanthropy if it has a very low administrative rate, right? And sometimes to get a good impact or a good outcome, not having the infrastructure is not all that helpful. And I could actually say sometimes chips away at what is possible by way of impact. one of the things we've done at Sierra Health is we started the center at Sierra Health, which is a philanthropic intermediary. It is designed to do some of that back office enterprise work so that communities of doers can really focus on what they are uniquely positioned to do. Some of the things and some of the skills, the talents, the assets, the relationships are not replicable. You can't just buy them. You can't just show up in the community and have trust because you showed up one day. Some of the characteristics of the most effective people to get to the outcome you want are things that have been developed over long periods of time and are not subject to the orthodoxy of traditional philanthropy. And I think we have to really recognize that. And that's not a plea to say that people should have administrative rates that are indefensible. That's not my point. But you got to have a level of infrastructure to collect the data, to understand and reflect on what you're doing, to make mid-course changes, right? In order to get the ultimate outcomes that you want. And that requires donors and funders to take a very different posture in terms of their relationship with the doers, right? To see yourselves both as a donor and doer on both sides of that equation. Because yes, you're a donor because you have resources, but you are a doer in the sense of you are trying to source credible organizations to pursue whatever you want to invest in. And if those folks who traditionally looked at as doers, they are also donors. Their time, the intellectual capital, the design of effective structures and projects and initiatives is also a donation back to that ultimate outcome. If it's simply transactional, if it's simply about who has money and who has not, then I would argue that the impact you're looking for is also secondary. Right? It has to be about what you want to achieve and the relationships and the intersectionality you need to have in order to achieve it. I had a colleague in the Central Valley tell me, no one lives a single issue life, Chet. No one. And I think in the design of intervention, no one's simply any one thing. You may be a leader at one point and a listener or a follower at another. But we all have multiple roles to play when you are addressing deep and complex challenges. And I think holding that up as your framework for engagement is a really important way of thinking about achieving the outcomes you have, whether that's in education or health or delivery of foods and meals. I don't really think that matters as much as the framework you're actually bringing to the work. Because the appropriate framework, I think you can address almost any issue. And you can make an impact against almost any issue. Maybe not resolve it completely, but I'm talking about making a real transformative, difference. And we have tried to think about what roles we need to play. One other example, last example I'll give you is that, we use a lot of our grant making on the foundation side to develop funds to do things. Almost like if I was an investment fund manager. We put money in, other folks put money in, we dilute power and authority, we bring community in, and then we don't talk about what the source of money was. We talk about what we're all here to achieve. And my experience is that it leads to very different conversations when folks are are made not to feel like they are lesser participants in whatever activity we have going on, that they are equal to partners where respect and dignity is afforded to them like you would afford the high net worth folks who may be sitting in that room at the very same time. The level of fear, the reluctance to engage and tell the truth about what's not going right is a really important, characteristic to have in that environment so that you can actually be as effective as you really want to be. You got to create environments where truth leads, data leads, and partnership is the superstructure for all that you actually do.
Thank you. So I have like 7 more pages of questions that I didn't get to, and I had a clearly very ambitious hope for this time. But I got the signal that we're at time, and I actually think that's a lovely place to end, if that's okay. We did have a closing question around kind of the culture of solidarity between philanthropy, and I actually think you answered that so beautifully, so thank you. I think something we often tell ourselves is that people that are closest to the problem are closest to the solutions. And I think that Isabel, you said that, and I hear all of you kind of echoing that. And I really, I sort of leave that as the idea for what post-COVID health equity work really needs to look like is actually getting solutions from people that are struggling with the structural conditions that have created vulnerabilities in their communities in the first place. And that those folks should guide our path forward. We deeply believe that, and I think the people that you've heard from today kind of believe that that's necessary for transforming our social contract here. Housekeeping, I think there's about 30 minutes? No, 20 minutes, 15 minutes. You have 15 minutes to stretch your arms, your legs, your neck, and get some refreshments. And the ask is to please come back to this room at 4 o'clock for the next session on amplifying people-powered change. So thank you. If I could just get a round of love for our speakers.
Thank you, Lydie.
Yeah, thank you so much.
More already?
Yeah. Thank you all.